All right, so here we're going to start talking about the pulmonary system. And on this slide you see pulmonary system, structure, function, and alteration, and chapter 26 and 27. The first 4 or 5 slides are from chapter 26, and it's just really very basic review. So I'm not going to spend really any time on it. You guys can look through the notes and look through the material underneath the slide just to show you what points I want you to get from those figures, and it really is review. Alright, so here talking about pulmonary and bronchial circulation. The lungs definitely act as a reserve for the heart, specifically the left ventricle. This is also an important slide because it shows you the different types of alveolar cells, type 1, type 2, and this nice layer of surfactant, which is important when we start looking at some of the different alterations in pulmonary function. Then there's also, in terms of lung activity as well as circulation or cardiovascular, right, you've got this interface between the lungs tissue and then the red blood cell, and how you have oxygen moving across these two membranes and CO2 moving across both of those membranes. And this process takes about a quarter of a second, so it's very fast and it's very efficient, provided that both membranes are working properly and have the proper physiological appearance, so to speak. Alright, just some functions of the respiratory system in terms of linking the brain, the neuro control of breathing, physical mechanics of breathing, gas transport, and then pulmonary circulation. So you have 3 systems that are working quite intimately with each other. And just a quick review of gas pressure and looking at the different types of molecules, whether it be nitrogen, oxygen, CO2, and the fact that they're moving constantly. Just spend some time here looking at gas pressure, not necessarily at any numbers or memorizing any numbers, but use the numbers to give your mind a better understanding of what's going on. So inspired air, you have 159 partial pressure O2, but expired air, the oxygen drops to 127. So why is that happening? Because oxygen is moving from the lungs into the blood, and it's disappearing. All right, then CO2, we're breathing in, should be breathing in very little CO2, but then we're expelling a lot. And that's going through, moving through the blood, and back into the lungs. All right, so then chapter 27 specifically, nice list of objectives here. Objective 1 talks about a variety, or wants you to be able to define a variety of different pulmonary alterations: dyspnea, cyanosis, clubbing, cough, hemoptysis. All right, those are on basically one slide. Pulmonary edema is a big one, and then describing atelectasis. So for Friday's quiz, you're going to have to know objectives 8 and 9 from the cardiovascular system, and then objectives 1 through 3, which would be these 3 here, obviously. We'll see how long this takes. It may just cut it down to objectives 1 and 2 from the pulmonary system being on the quiz. But looking at the basic issues of pulmonary alterations. All right, very basic one of dyspnea, uncomfortable breathing, inability to feel like you're getting enough air. And signs of this is going to be flaring of nostrils, using accessory muscles in the chest, and it's just going to look like someone is trying hard to breathe, when in all reality it should be something you do all the time without even having to think about it. You can also look at breathing patterns, right? The rate, the depth, regularity, and then the effort of your breathing can indicate whether or not there is some sort of pulmonary issue. All right, you can have labored breathing, there can be panting, you can have Cheney strokes respiration, hypoventilation, hyperventilation. Hypoventilation is going to indicate an inadequate meeting of the body's metabolic needs. Hyperventilation leads to hypocapnia, right, breathing out CO2 at a much faster rate than what the body produces metabolically. And if you leave, or if you get rid of too much CO2, then you're going to end up developing respiratory alkalosis. Alkalosis, you're pulling out, getting rid of the CO2, which is going to help make carbonic acid. Without that carbonic acid, the bicarbonate is going to build up, and it would be classified as respiratory because it is occurring because the person is hyperventilating, an issue with the lungs. All right, the hypercapnia, too much CO2, hypocapnia, too little CO2, can be determined by the blood gas analysis. All right, then some other ones for objective one. Cough, protective reflex to cleanse the lower airways. So just what I did now, sort of. Getting rid of material out of the airways, at least trying to, actually helps clear material, clears any garbage that may be trying to get down into your lungs. All right, that mucus is going to help to trap material, whether it's bacteria, whether it is dirt from the air. You don't want that material getting down into the lungs where it can cause obstructions, where it can cause inflammation, where it can cause actual infection. So we cough multiple times a day, pretty normal. You generally don't think about that as an issue. It's when you have a cold or you have pneumonia, bronchitis, then you start coughing a lot, then it becomes a problem. But it really is a protective reflex. Hemoptysis, coughing up blood, not a good sign. And usually the blood is going to be bright red because it isn't going to have been digested in any way. Cyanosis is the bluish discoloration of skin due to lack of oxygen saturation within the red blood cells or decreased hemoglobin content. It can be central, decreased amount of hemoglobin saturation, and so you're going to have an issue throughout the entire body, or it can be peripheral, slow circulation to the toes and fingers. And in that case, the hemoglobin content and saturation might be just fine, but it's simply an issue of slow circulation and getting those red blood cells out to the exterior of the body. All right, pain, usually located by pleural friction rub, heard over the painful area. This can indicate infection, embolism, inflammation, allergies, even cancer of some sort. And then clubbing, which we'll look at on the next page. This is enlargement of the end of the fingers or toes, sometimes associated with diseases that interfere with oxygenation. So this could be lung cancer, cystic fibrosis, pulmonary fibrosis, lung abscess, congenital heart disease. And what you see is here the nail bed and the nail are pretty flush. All right, I don't see a whole lot of difference between this picture and that picture, but here you can start to see more of a raised effect right here. in the nail bed, and that is due to hypertrophy. All right, this is going to be an enlargement of the cells, and it's going to be due to an accumulation of protein. It's not an accumulation of fluid, but rather accumulation of protein. Protein synthesis is activated, so the protein is going to accumulate in those cells, giving this bump in the nail bed. All right, it can be graded on a scale of 1 to 5 versus, early, moderate, severe, and it can also be due to issues that cause chronic hypoxemia. All right, now just some diseases or injuries that can occur. Pulmonary edema. This is going to be excess fluid in the lungs, right? That water is probably not the right word, but rather fluid. There can be atelectasis. This is going to be a collapsed or airless state of the lung. You can have a compression atelectasis where the lung tissue is being compressed, and that's usually due to a tumor. And so the lung tissue is compressed, and that can also look like it being collapsed, but there's not going to be any air getting into that area of the lung. There can be absorption atelectasis, which we'll talk about further down. And then there can be issues with surface impairment or surfactant impairment. The surfactant is going to be produced by the type 2 alveolar cells, and that's going to help with alleviating surface tension in the alveoli and helping air to move across the two membranes. There's bronchiectasis, persistent abnormal dilation of the bronchi, and then aspiration, passage of fluid or solid particles into the lungs. This could cause coughing immediately, but that coughing reflex might not be strong enough to actually move material out of the lungs. All right, now back to pulmonary edema. Pulmonary edema develops because of 3 major issues. All right, and this is objective 2. So down here at the bottom, you have pulmonary edema. Why does that occur? Well, it occurs because of heart disease. Right? A variety of different types of issues with the heart can cause increased left arterial pressure, increased pulmonary capillary hydrostatic pressure. If you go back to chapter 4, you can remind yourself of what this means, but increased capillary hydrostatic pressure means that fluid is going to move out into the tissue, and that's going to be the lung tissue, which means you have pulmonary edema. All right, but all of this is heart disease. Then injury to capillary endothelium. That leads to capillary permeability, disruption of the surfactant production, and then movement of fluid and plasma protein from the capillary to the interstitial space. Then blockage of lymphatic vessels. All right, that causes a backup of fluid behind that blockage, and then inability to remove excess fluid from the interstitial space, and that fluid then just accumulates in the interstitial space. So all 3 of these, if you have a question, what is the mechanism? What are the 3 mechanisms? What are the 3 major issues that lead to pulmonary edema development? All right, this is your answer.